Thank you. I'm real honored to be here. So again, I'm a Navy guy. I'm going to just make that very clear. Absolutely. My dad was Air Force. I was a real flyer. So, great opportunity to be here. I'll give you the quick elevator speech. Number one is I'm on the demand side of the blood safety chain, the blood value chain. I'm an anesthesiologist, so I administer blood products. And what I saw from the beginning of my career was really inefficiencies in terms of ordering practices. Over time, I've sort of learned the entire value chain from vein to vein, as we'll talk about here, and I understand now better on the blood collection side, there are also inefficiencies as well. So I'm, again, an anesthesiologist, past president of the Indiana State Association of Blood Banks, and a member of the medical advisory committee of the Indiana Blood Center. So looking back briefly, our historical view of blood safety and availability last century, last millennia, is this is the job of the Indiana Blood Center, the American Red Cross. They need to take care of getting an adequate blood supply and making it safe. So that was the concept of blood safety, and they have done a remarkable job of doing that. The more modern view, which is more patient-centered and I think more efficiency, is looking at vein-to-vein safety and a vein-to-vein value chain, making sure that we are safe and efficient all the way from donor to recipient. And it turns out that most of the inefficiencies, both in terms of safety, quality, and operations, lie within our hospitals, St. Vincent, Indianapolis, Clarion, etc. That's where they focus it. So the concept of what we talk about as blood management is making sure that blood is used appropriately throughout this particular chain. Why should you want to get involved in this particular project? I'll give you the elevator speech that I give to all hospital administrators. Number one, blood is number one. It's the single most frequent therapeutic procedure in U.S. healthcare. Number one procedure. Number two, it is a high-risk procedure based upon more modern risks and benefit studies of blood products. We now know it's less beneficial and more harmful, meaning we have a narrower path to tread between risks and benefits. Number three, it is very expensive. Alan said it costs $200 to buy blood, costs over $2,000 to administer it, looking at associated supplies, nursing time, reagents, adverse events, and I know that because I have a Butler MBA and I wrote a book chapter on that. And then finally, high volume, high risk, high cost, poorly utilized. Over half of blood in the United States, by my expert opinion, is inappropriately ordered or administered based upon misjudgment of, again, good center practices. So again, this is why we think you need to help us with this. In terms of blood safety, I've mentioned that the blood donor centers do an excellent job of going through blood safety, but on our watch in our hospitals, we have 5 critical points: pre-analytical testing, the medical decision to transfuse, issuance and transport, bedside identification, and monitoring patients. In all of these areas, we see inefficiencies that result in both safety issues, compliance issues, and frankly, operational/cost issues as well. So what we're trying to do is improve technologies that would help, number one, reduce inefficiencies between supply and demand. Alan noted that although there are regional blood shortages, there is a blood surplus because we do not tie together supply and demand, over-collection and under-collection. Number two is we have ordering practices within the hospital that are inefficient. For example, a cardiac surgeon that has to have blood products at the bedside to know that it's available, he doesn't use those blood products, they're then wasted because they set out and expired too long. And that could be up to 7 to 10% of wastage within the hospital environment. Number three is the decision to transfuse. Beyond the scope of this, but we see that CPOE, intelligent ordering, can help physicians drive that practices. The next thing is issuance and transport. When the blood is adrift and it leaves the hospital secure blood bank, it goes to the wrong place, which is both a safety issue and an operational issue. Finally, getting down to the last pieces in the process that are critical: bedside administration and identification. Believe it or not, 1 in 16,000 patients in the United States still receives the wrong unit of blood. 1 in 16,000 patients receives the wrong unit of blood because of bedside errors associated with patient ID issues at the bedside, and it's a number that has not changed in 30 years. So we have a lot of opportunities that equate to quality, safety, operational cost issues that could be improved through better blood technology, better blood tracking, better blood IT, essentially. So the possible technology solutions, and I'll have Troy take it the final piece here, to help some of these inefficiencies, quality, safety, regulatory, operational, are coding, Certainly, the U.S. blood industry has gone to standardized blood coding, and there are many hospitals using barcoding technology currently, for example, for medications and other products as well. The downside is there's many different barcode readers. There still is not a standardization even between barcode readers for medications versus blood. Believe it or not, they often don't match. No standardization and again, no repository. Radio frequency ID, which we put a lot of hope behind, although it's underutilized, grossly underutilized in the paper space. They are more standardized and easier to use. The con is currently in the at least U.S. healthcare industry, the technology is not widely accepted. Now, it is interesting, DoD, Department of Defense, mandates that all of their vendors will barcode things within the entire supply chain, including the medical supply chain. We all know about Walmart's use of RFID. I think that the healthcare gross domestic product investment in healthcare is greater than Walmart or the Department of Defense, so we are lagging in this particular area. And then additional challenges, which Troy is an expert on, is RFID can also help with clinical workflows. Not only where is that bag of blood on any given time, in any particular date in the supply chain, all the way from the Indiana Blood Center to the operating rooms at IU Health or St. Vincent, and also then integration. We don't want extra work as physicians and nurses. We don't want to do charting over here and then additional charting or work from that standpoint. So all of these, I think, are opportunities that need to be solved, and we'd like to have. Thanks, Jim.